Hi friends, welcome back to the channel. In this small presentation, we will discuss a very important topic in endocrinology, that is thyroiditis. So firstly, we will discuss that what is thyroiditis, then the classification and causes of it. We classified it into acute, subacute and chronic thyroiditis. Then we will discuss some drugs causing thyroiditis, approach to the patient, and finally we will solve some MCQs with the help of this presentation. Now, some of the students are very much confused between thyroiditis, hyperthyroidism and hypothyroidism. So, thyroiditis basically mean inflammation of thyroid gland. So, when there is inflammation of any tissue, what will be the presenting feature? So, most of the patients will present with the pain in the gland, but there can be various stages of thyroiditis. Like initially there is hyperthyroidism, then the patient lands up into hypothyroidism, then becomes euthyroid. So according to the stage, there will be additional symptoms of thyrotoxicosis, hypothyroid, etc. When we consider the classification of thyroiditis, it is based on the onset and duration of the disease. So we will discuss various causes as per the onset of thyroiditis. So it can be acute when the onset is within days, subacute when the onset is within weeks and the disease lasts for up to months, and chronic thyroiditis is the one which lasts for months to years. So let's try to remember some important points first. In acute thyroiditis, that since it is most commonly due to suppurative infection, the WBC count and ESR will be high, but the thyroid function test will be normal throughout. In subacute thyroiditis, the ESR can be high or normal, but thyroid function test will be abnormal as per the stage of thyroiditis. We will discuss in detail the various stages of subacute thyroiditis. Finally, in chronic thyroiditis, in thyroiditis stage, the thyroid function test will be normal, but most of these patients later lead to hypothyroidism. So when the patient becomes hypothyroid, the thyroid function test will again be abnormal. Now let's discuss the causes. So acute thyroiditis is basically due to suppurative infection, which can be bacterial infection, especially due to staphylococcus, streptococcus, enterobacter. In immunocompromised host, fungal infection can lead to thyroiditis like Aspergillus, Candida, coccidioid, histoplasma, pneumocystis. Radiation thyroiditis, especially after iodine 131 treatment. We have discussed in the treatment of Graves' disease that iodine 131 is used for treatment of Graves' disease, then solitary thyroid nodule, which is hyperfunctioning nodule, etc. So it can also lead to thyroiditis. This is known as radiation thyroiditis. Finally, amiodarone, it can lead to acute, subacute as well as chronic thyroiditis, which we will discuss in detail in some other lecture. Now, subacute thyroiditis can be due to viral infection. It is also known as granulomatous thyroiditis. We will discuss that this is also known as de Quervain thyroiditis. Then subacute thyroiditis also has silent thyroiditis, which has painless goiter, which also includes postpartum thyroiditis. Then mycobacterial infection, again drugs like amiodarone can lead to subacute thyroiditis. Chronic thyroiditis is basically due to autoimmunity, be it Hashimoto's thyroiditis. Later stages of Hashimoto's thyroiditis become atrophic thyroiditis and the patient lands up into hypothyroidism. Then we have Riddle's thyroiditis in this, some parasitic infections and traumatic thyroiditis after palpation of the thyroid tissue. So basically, when we see the etiology, bacterial and fungal infections usually lead to acute thyroiditis. Viral and mycobacterial infections lead to subacute thyroiditis, while parasitic infections are leading to chronic thyroiditis. So this we have to remember. Also an important point, if it is not specified the particular type of thyroiditis will mean viral subacute thyroiditis, which is de Quervain's thyroiditis, as it is the most common type of thyroiditis. So if it is not specified, thyroiditis will mean subacute viral thyroiditis. Now we will discuss individually, first acute thyroiditis, then subacute thyroiditis, finally chronic thyroiditis. So acute thyroiditis is a rare disease and occurs due to suppurative infection of the thyroid gland. So how does the patient get this infection? So the most common cause in children or young adults is a presence of pyriform sinus, that is presence of pyriform sinus. Now what is this pyriform sinus? It is the remnant of fourth branchial pouch. It is remnant of fourth branchial pouch, and it connects oropharynx with the thyroid. It will connect oropharynx with the thyroid. So any infective etiology in oropharynx can directly reach the thyroid gland. It is most commonly present on left side. Therefore, acute thyroiditis most commonly presents with a asymmetric goiter. Now in elderly, any cause of long-standing goiter or degeneration in thyroid malignancy, this can be a risk factor for infection leading to acute thyroiditis. Now how will the patient present? The patient most commonly presents with thyroid pain. It is easy that there is suppurative inflammation, the patient will present with thyroid pain. Now this pain will be referred to throat as well as ear. On examination, we can palpate a small tender goiter, which is usually asymmetric. As we have discussed, the most common position of pyriform sinus is left-sided. So left-sided goiter is most commonly seen. There can be fever, dysphagia, erythema over gland on examination, lymphadenopathy, all this can be seen, and patient can also have toxic features of a acute febrile illness. Now it is important to note that there are some important causes of thyroid pain. So what can be the causes of thyroid pain? What can be the differentials of thyroid pain? So firstly, thyroiditis, be it acute, subacute or chronic, as it is the inflammation of thyroid gland, it can lead to pain in the gland. Then a patient who has long standing cyst, thyroid cyst, if there is sudden hemorrhage into the cyst, the patient can present with thyroid pain. Presence of malignancy can be there as a cause of thyroid pain. Then amyloidosis and thyroiditis due to amiodarone. So all these causes can lead to thyroid pain. Now coming on to the lab evaluation, what all lab findings will be seen in acute thyroiditis? So as it is most commonly infective, the ESR and WBC count of the patient will be increased. Now the inflammation in acute thyroiditis is not much as compared to subacute thyroiditis. So there will be no destruction of the gland and no release of preformed thyroid hormone. So the thyroid function test will be normal throughout this condition. We can do FNAC, which will show predominantly polymorphonuclear neutrophil infiltration. Culture can be done for identification of the organism, and it is important to note that in immunocompromised patient, causes can be fungal, mycobacterial, pneumocystis. So we have to do the culture accordingly. Now, what is the treatment of this condition? So we will give the antibiotics. Basically, this will be guided initially by the gram stain, and finally after the culture sensitivity reports, we can give guided antibiotic therapy. Surgery can be done if there is abscess. So for abscess drainage, we can go for surgery, but still there are some complications of this condition. What can be the complications? There can be tracheal obstruction due to thyroid swelling. The patient can end up into septicemia, multi-organ dysfunction. The abscess can reach the retropharyngeal space, leading to retropharyngeal abscess. There can be mediastinitis if the abscess reaches the mediastinum, and there can be jugular venous thrombosis. So all these can be the complications of acute thyroiditis. Now coming on to the subacute thyroiditis. So in this entity, we'll mainly discuss two conditions in detail. First one is viral thyroiditis, which is also known as decurvin thyroiditis or granulomatous thyroiditis. Secondly, we'll discuss silent thyroiditis. So when nothing is specified, thyroiditis means viral subacute thyroiditis, which we are discussing right now. So the other names of this viral thyroiditis is decurvin thyroiditis or granulomatous thyroiditis. So which viruses are implicated in the causation of this subacute thyroiditis? These include mumps, Coxsackie, influenza, adenovirus, ecovirus. But this virus identification in etiology will not affect the management of this condition. So most commonly a question is asked that which of the following viruses can lead to viral thyroiditis except. So the option will be measles. So the correct answer would be measles, as it do not cause viral thyroiditis, but mumps causes viral thyroiditis. Now symptoms of this can mimic pharyngitis. Patients are usually in 30 to 50 years of age group, and this condition is more common in females in a ratio of 3:1. Now when we consider the pathophysiology, the gland shows a characteristic patchy inflammatory infiltrate. There is inflammation with disruption of thyroid follicles. There is formation of multinucleate giant cells. Later, there occurs granulomatous fibrosis. Now, it is important to note that all these extensive changes of inflammation, all of these are reversible. Even after this much granulomatous inflammation, formation of multinucleate giant cells, the changes are reversible, which usually takes some months. After the onset, there are three phases of this condition. First, the patient lands up into hyperthyroid phase, then there will be hypothyroid phase, then finally there will be recovery in the form of euthyroid phase. So initially thyroid function test will be T4 high, TSH low, then hypothyroid phase T4 low, TSH high, then thyroid function test will be normal. So on the next slide, we will discuss these three phases in detail. What can be the clinical manifestations? The patient usually presents with a painful, enlarged, small goiter, sometimes accompanied by fever. There may be features of thyrotoxicosis like palpitations, anxiety, fatigue, then there will be hyperdefecation, or there can be symptoms of hypothyroidism like weight gain, low appetite, etc., depending on the stage of thyroiditis. URTI may precede the thyroid related features by several weeks. Now complete resolution is usually the rule. First there will be hyperthyroid phase, then hypothyroid phase, then euthyroid phase, that is recovery. But it is seen that late onset permanent hypothyroidism is seen in 15% of the cases. So what all are these 15% of the cases? These are the one which have coincidental thyroid autoimmunity. So if the patient have TPO antibody positive and this patient develops subacute thyroiditis, there is high risk of this patient to develop permanent hypothyroidism. So this is just a coincidental finding. If the patient has thyroid autoimmunity, this patient can land up into hypothyroidism. As such, this viral thyroiditis undergoes recovery, that is euthyroid stage. Now the three stages of this viral thyroiditis. So the first stage is thyrotoxic stage. So this stage is not equal to hypothyroid stage. So hyperthyroidism means that gland is hyperfunctioning, but this thyrotoxicosis is due to release of preformed thyroid hormone. So this is not hyperthyroidism, but this is termed as thyrotoxicosis. So all the causes of hyperthyroidism are included in thyrotoxicosis, but not vice versa. So what will happen? Due to the inflammation by viral etiology, there will be destruction of thyroid gland. There will be release of preformed stored thyroid hormone T3 and T4 in the circulation. There will be increased thyroglobulin in the circulation, and there will be the symptoms of thyrotoxicosis. So normally when we see, our thyroid gland is about 25 grams in size and it has stored hormone of about 5000 microgram, which is predominantly T4. Now due to sudden destruction and release of this thyroid hormone, there will be release of all this preformed thyroid hormone in the circulation, and this will lead to the symptoms of thyrotoxicosis. This storage is about for 50 days. So all of the thyroid hormone which was stored for next 50 days is released suddenly, this will lead to the first stage, that is thyrotoxic stage. Now this will last for about 6 weeks. Then there will be depletion of stored thyroid hormone. Then there will be stage of hypothyroidism. The TFT will show a increase in TSH and decrease in T4. This stage will again last for about 6 weeks, and after that there will be TSH mediated recovery. The TSH will stimulate the thyroid gland to produce more of T4 and T3, and there will be euthyroidism. So these are the 3 stages of subacute viral thyroiditis. Now when we discuss the radioactive iodine uptake, so in the first stage, as the gland is releasing its preformed thyroid hormone and not forming the thyroid hormone, the radioactive iodine uptake in the first stage is actually decreased. In the hypothyroid stage, it has started forming the new thyroid hormone to replete the stores. So the radioactive iodine uptake will increase in the hypothyroid stage. This is basically due to the effects of TSH, and finally in euthyroid stage it will be normal. That is, the uptake in both salivary gland and thyroid will be equal. So what happens is, this iodine uptake, be it radioactive iodine or elemental iodine which is required for thyroid hormone synthesis, this occurs through sodium iodide symporter. This is present in thyroid gland, salivary gland, mammary glands, etc. So we compare with the salivary gland. So if the thyroid gland uptake and salivary gland uptake is equal, then the radioactive iodine uptake is considered as normal. Coming on to the lab evaluation. So there are 3 distinct phases over a period of about 6 months. So in thyrotoxic phase, what happens is, this is basically to differentiate it from Graves' disease. The T4 to T3 ratio is greater. So what happens is, normally we see T3 to T4 ratio. So it is less than 15:1 in thyroiditis, while it is more than 20:1 in Graves' disease. Now what happens is, the major storage form of the thyroid hormone is T4, and there is release of preformed thyroid hormone in thyroiditis. So there will be more of T4 which is released, but at the end it will be converted to T3 in the peripheral circulation. But still the T3 to T4 ratio will be less than 15:1, as more of T4 is being released. But what happens in Graves' disease, on the other hand, there is hyperfunctioning of the gland. This is a cause of hyperthyroidism. So due to hyperfunctioning of the gland will try to make the hormone fast. So in this fast process of making the hormone, it will make more of monoiodotyrosine than diiodotyrosine. So this conjugation will lead to more of T3 formation than T4 formation. So in peripheral circulation also, the T3 will be much more higher than T4 as compared to thyroiditis, and this ratio will be more than 20:1. Similarly, similar to the acute thyroiditis, there will be high ESR and WBC count in the thyrotoxic stage, as it is caused by viral infection. In thyrotoxic stage, the radioactive iodine uptake will be low. Technetium pertechnate uptake will be less than 5%. This is also compared to the salivary gland. So it is less than 5% as compared to the salivary gland. Thyroid and autoantibodies will be negative. If these are positive, like TPO antibodies, the patient is at high risk of developing permanent hypothyroidism. Now what will we give for treatment? So large doses of aspirin or other NSAIDs are given. Usually aspirin dose is about 600 milligram, which is given every 4 to 6 hourly. This is given for the pain management, fever management, basically the symptomatic management. If this aspirin is inadequate or the patient have marked local and systemic features, glucocorticoids can also be given. So the dose of prednisolone for this condition will be 15 to 40 milligram per day, and this has to be tapered over a duration of 6 to 8 weeks. Thyroid function monitoring has to be done every 2 to 3 weeks. Beta blockers can be given for the symptoms of thyrotoxicosis, Now, it is very important to note that there is no role of anti-thyroid drugs in the treatment of this thyrotoxic stage of thyroiditis. But levothyroxine has to be given if the hypothyroid stage is prolonged. Now, it is again important to note that the full dose, that is 1.6 microgram per kg, is not to be given. Around 50 microgram daily dose is given of levothyroxine so that it does not suppress the TSH, and TSH mediated recovery which occurs in hypothyroid phase later leading to euthyroid phase can occur in this condition. Now here only let's discuss the differences between de Quervain thyroiditis and Graves' disease. So de Quervain thyroiditis have history of around weeks. We have discussed 6 to 12 weeks. While Graves' disease is a chronic disease, it will be having symptoms for months before the presentation. It is more common in females in the ratio of 3:1, but Graves' disease is much more common in females. Thyroiditis can present at any age. Graves' disease is usually in the middle age. Clinically, the patient progresses first from thyrotoxic stage to hypothyroidism, then euthyroidism. In Graves, the patient is in permanent hyperthyroid stage if the treatment is not given. Thyroid function test will be variable similarly. Firstly, there will be increased T4, suppressed TSH, then there will be increased TSH, suppressed T4, and finally the TFT will become normal. In this Graves' disease, the patient will be hyperthyroid throughout. Thyroid receptor antibody will be negative in this, but it is positive, that is causative of the Graves' disease. Ophthalmopathy is diagnostic of Graves' disease. Then goiter, we have seen that small goiter can be seen, which can be absent also in thyroiditis, but diffuse symmetrical goiter is commonly seen in the Graves' disease, but it is not seen in 100% cases. It is about 50% of the cases that Graves' disease has goiter. On the other hand, about 1/3 of the patients will have thyroid ophthalmopathy in Graves' disease. Ultrasonography, if we do in that is thyrotoxic stage, it will be hypovascular, while there will be diffusely enlarged thyroid gland with hypervascularity in Graves' disease. T3 to T4 ratio we have discussed in detail. It is less than 15:1 in thyroiditis, while more than 20:1 in Graves' disease. Radioactive iodine uptake is variable, while it is increased in Graves' disease. So radioactive iodine uptake in the first stage will be decreased. In the second stage will be actually increased due to the effects of TSH. TSH will stimulate the thyroid gland to form the more hormone. Therefore, it will uptake the radioactive iodine, and in third stage it will become normal. The radioactive iodine become normal. So with this, we have completed the discussion on de Quervain thyroiditis. Now coming on to the second important entity in subacute thyroiditis, that is silent thyroiditis. As the name suggests, silent thyroiditis is also known as painless thyroiditis, as the patient will have no features of inflammation and pain in the gland. It occurs in patients with underlying autoimmune thyroid disease. So it is very important point to note that this is a differentiating feature between viral thyroiditis and silent thyroiditis, that these patients have underlying autoimmune thyroid disease and have clinical course similar to subacute viral thyroiditis. There will be 3 stages. First stage of thyrotoxicosis, then hypothyroidism, then euthyroidism. Now the condition occurs in about 5% of the pregnant females 3 to 6 months after delivery. Therefore, the term postpartum thyroiditis is given. So same 3 phases are there, but these phases are briefer as compared to the viral thyroiditis. So in viral thyroiditis, first stage was 6 weeks, then second stage was 6 to 12 weeks, and there was recovery in 6 months. But in this, thyrotoxic stage is 2 to 4 weeks, then hypothyroid stage is 4 weeks, then there is resolution. So the resolution will occur by 3 to 4 months. TPO antibodies are present in this condition, which is the differentiating feature from viral thyroiditis, and it is more common in conditions of other autoimmunity like type 1 diabetes. So the patient who have other autoimmune diseases like type 1 diabetes are at increased risk of this silent thyroiditis. Radioactive iodine uptake, technetium-99 uptake will be decreased in thyrotoxic stage. So what are the features which differentiate it from subacute viral thyroiditis? Firstly, it is painless goiter, ESR, WBC count will be normal, there is presence of TPO antibodies, and since there are no features of inflammation, the glucocorticoids or NSAIDs are not indicated for the treatment. So what is used for the treatment? Basically, severe thyrotoxic symptoms can be managed by brief course of propranolol, which is given in a dose of 20 to 50 milligram every 6 to 8 hourly. Then in hypothyroid phase, we can give levothyroxine for 6 to 9 months, after which it is withdrawn for recovery to occur. Annual follow-up has to be done with thyroid function test, as some of the patients can develop permanent hypothyroidism. So since it is associated with TPO antibodies, some patients can develop permanent hypothyroidism. Now finally coming on to the chronic thyroiditis. So the most common clinically apparent cause of chronic thyroiditis is Hashimoto's thyroiditis. So it can present with firm, hard goiter. TPO antibodies are usually positive in this thyroiditis. In this stage of inflammation, the thyroid function test in chronic thyroiditis will be normal, but later the patients lead to hypothyroidism, later developing atrophic thyroiditis. In that phase, there will be frank hypothyroidism. Another cause of chronic thyroiditis is Riddle's thyroiditis. Basically, it is a rare disorder which is a part of IgG4 related disease. In this, there is deposition of IgG4 secreting plasma cells in thyroid gland. It typically occurs in middle-aged females, 30 to 60 years of age group, presents with insidious painless goiter but with local symptoms. So local symptoms are predominant in Riddle's thyroiditis. What can be the local symptoms? There can be compression of esophagus, trachea, neck veins leading to SVC syndrome. Then there can be recurrent laryngeal nerve palsy. On examination, that is on microscopic examination, this condition is characterized by dense fibrosis which disrupts the normal gland architecture. Goiter is typically hard, non-tender, asymmetrical and fixed. Therefore, it is also known as wooden thyroiditis, woody feel thyroiditis. After all this fibrosis and all, thyroid function test is usually normal. Diagnosis requires open biopsy as FNAC is inadequate. For treatment, we go for surgery for the relief of compression of esophagus, trachea, neck veins as we have discussed. And tamoxifen also has a role in this condition, but it is controversial. How much beneficial is tamoxifen? We do not have much of the studies. Now, it is also associated with other IgG4 related diseases like retroperitoneal fibrosis, mediastinal fibrosis, primary sclerosing cholangitis, autoimmune pancreatitis, etc. Now, an important slide, that what all drugs can lead to thyroiditis. So, interferon alpha, which is used in the treatment of chronic hepatitis B, chronic hepatitis C and some malignancies, is associated with thyroiditis in about 5% of the cases. Tyrosine kinase inhibitor like nilotinib, etc., which are used for various malignancies, these can lead to thyroiditis. Lithium can lead to goiter, which is associated with hypothyroidism. Now, basically lithium, what it does is it decreases the thyroid hormone release through inhibition of the colloid pinocytosis. That is, the colloid is not uptaken by the thyroid gland, therefore it will lead to hypothyroidism. It will not be able to uptake the colloid, and there will be painless thyroiditis in lithium therapy. Painless thyroiditis in lithium therapy, and it is associated in 10% of the cases who are taking lithium. Then immune checkpoint inhibitors, especially PD-1 inhibitors. Now, what these immune checkpoint inhibitors do? These are used for cancer therapy. So what these do is these bring the autoimmunity of body against the cancer cells. So basically these will act against cancer cells, but since autoimmunity is activated, it will also affect the normal structures of the body like thyroid. So it will lead to thyroiditis most commonly, followed by type 1 diabetes. Amidron itself can lead to thyroiditis. There are basically two types: type 1 thyrotoxicosis, type 2 thyrotoxicosis. Type 2 is basically a form of thyroiditis which is similar to destructive thyroiditis. Destructive thyroiditis. So it is a homework for all of you that you have to write all the features of amiodarone induced thyrotoxicosis in the comment section. This is the homework. Now this is a very important slide of approach to a patient of thyroiditis. So in each patient, if the patient is presenting with the painful goiter or even painless goiter and we are suspecting thyroiditis, how we will approach to this patient? So first question which we will ask is there associated thyroid pain? If there is thyroid pain present, then we will see whether the patient is toxic or not. That is, whether the patient is having features of febrile illness or not. If yes, it can be infectious thyroiditis like acute thyroiditis as well as viral subacute thyroiditis. If there are no features of toxicity, then we will ask whether there is history of any radiation or trauma or not. If yes, this can be radiation or trauma induced thyroiditis. Even during palpation, thyroiditis can occur. If there is no history of radiation of trauma, we will see the levels of TSH, whether the TSH is low with high thyroglobulin level or not. If yes, it can be subacute thyroiditis in the first stage, that is thyrotoxic stage. If no, then this can be due to thyroid pain due to thyroid hemorrhage. So we discussed that pain can be due to hemorrhage in the thyroid cyst. So this can be the cause of the thyroid pain. If there is no thyroid pain, then we will take the drug history, whether the patient is taking amiodarone, interferon alpha, any PD-1 inhibitor. If yes, then this can be drug-induced thyroiditis, which is a painless thyroiditis. If no, we will measure the TSH levels. If TSH levels are high, patient is postpartum, then this can be a Hashimoto's thyroiditis, that is hypothyroid phase. In late stages, Hashimoto thyroiditis will end up into hypothyroidism. This will be associated with high TSH. If the TSH is high and patient is not postpartum, then it can be Hashimoto or silent thyroiditis or even subacute thyroiditis in the hypothyroid phase. If the TSH is low, patient is postpartum, we go for thyroid scan. If thyroid scan is showing low uptake, it can be postpartum thyroiditis, the first stage itself. If it is high, even if the patient is not postpartum, the high radioactive iodine uptake can be due to Graves' disease. If the patient is having low TSH levels, patient is not postpartum, and thyroid scan with radioactive iodine uptake is low, this can be silent or subacute thyroiditis in the first, that is thyrotoxic stage. So this is a slightly complicated approach, but it is very important. Now with this all knowledge, we'll try to answer some multiple choice question. So first question is, all are true regarding thyroiditis except. Postpartum thyroiditis is associated with painless goiter. It is true, as it is a silent thyroiditis. Measles can lead to subacute thyroiditis. This is a false statement. Mumps, ecovirus, Coxsackie virus, all these can lead to subacute thyroiditis, but measles do not lead to subacute thyroiditis. Acute thyroiditis is usually due to suppurative bacterial infection. This is also true. So the correct answer to this question will be option B. Second, tamoxifen is used in treatment of, directly we can answer, that is Riedl's thyroiditis. Decurvin thyroiditis is the other name for viral subacute thyroiditis. For treatment, we use NSAID or glucocorticoids for symptomatic management. In hyperthyroid phase, we can use propanol. Is there any role of antithyroid drugs? No. In hypothyroid phase, we can use thyroxine therapy. Similarly, in silent thyroiditis, since there are no painful symptoms, no inflammatory symptoms, NSAIDs, glucocorticoids are usually not used. Propanol can be used for that is thyrotoxicosis stage, and levothyroxine can be given for hypothyroid stage. Similarly for postpartum thyroiditis. So tamoxifen is for Riedl's thyroiditis. Last question, all are true regarding thyroiditis except there can be variable radioactive iodine as per the stage. True. Levothyroxine is used for treatment in hypothyroid stage. True. Anti-thyroid drugs are used for treatment in hyperthyroid phase. It is absolutely false. NSAIDs and glucocorticoids are used for symptomatic relief. This is also true. So the correct answer to this question will be option C. I hope I have covered almost all the important points regarding thyroiditis. Thank you so much.